Hey everyone, welcome back. You've officially made it to part 76 of our CPC exam series. Today, we are taking a massive deep dive into the absolute engine of evaluation and management coding, the AMA and CMS Medical Decision Making, or MDM, table. If you want to crush those high-yield CPC exam questions, you absolutely have to master these calculations. So let's get right into it. But real quick, before we start tearing down this incredibly complex MDM table into its fundamental building blocks, make sure to like, share, and subscribe to Decode Healthcare with Harshal. It seriously helps us keep creating these completely free, high-yield explainers to get you exam ready. Here is our roadmap for today's explainer. We're looking at problems addressed, data reviewed, and patient risk. Then, we'll cover the 2 out of 3 rule and wrap up with some common pitfalls and a summary cheat sheet.
All right, section 1, number and complexity of problems addressed.
Now, the golden rule here is we only score problems that are actively being evaluated and managed right now during the specific encounter. So imagine a patient comes in for a sprained ankle. If they have mild asthma just sitting in their past medical history, but you aren't doing anything about it today, yeah, that doesn't count towards today's score. Looking at the criteria, minimal is literally just one self-limited or minor problem. Low bumps up to 2 minor problems or 1 stable chronic illness. Now, moderate is where they try to trick you on the exam. Look closely for keywords like 1 chronic illness with exacerbation or systemic symptoms. And high complexity? That's when you're dealing with a severe exacerbation or an acute threat to life or bodily function.
Moving right along to section 2, amount and/or complexity of data to be reviewed and analyzed.
Okay, I know this is notoriously the most mathematically complex part of the whole MDM table, but let's simplify it. Just think of it as 3 distinct buckets. Category 1 is your standard review stuff, checking prior external notes, ordering a unique lab test, or reviewing a test result. Category 2 is when you independently interpret a test that someone else performed. Think of a doctor looking at the actual X-ray image themselves instead of just reading the radiologist's report. And Category 3? That's when the provider actually picks up the phone to discuss management or test interpretation with an external physician or qualified healthcare pro.
So how do we actually score this data mathematically? Well, to hit limited, you just need to meet the requirements for 1 of 2 available categories. For moderate, you have to meet 1 of 3, like, say, reviewing 3 unique tests or notes to satisfy Category 1. And to reach extensive data, you actually have to hit the requirements for 2 out of the 3 categories entirely. It's like a giant puzzle, but once you know the pieces, it totally clicks.
Next up, section 3, risk of complications and/or morbidity or mortality of patient management.
This element is driven completely by the provider's management interventions and the potential morbidity of those choices. Notice how specific clinical actions lock you into each tier. Minimal risk is super basic, just rest or superficial dressings. Low risk bumps up to over-the-counter medications. Now please pay close attention here. Moderate risk? The moment a provider initiates or manages prescription drugs, boom, you're automatically locked into moderate risk. For sure, remember that. High risk involves serious stuff like drug therapy requiring intensive monitoring for toxicity or making decisions about emergency major surgery.
All right, section 4, applying the 2 out of 3 rule.
So now that we have all 3 pieces out on the table, it's time for the reassembly phase. This is the absolute golden rule of MDM scoring right here. To qualify for a final EM code level, you only need to meet the requirements for 2 out of the 3 elements. That means you can literally drop your lowest score. How great is that?
Here is the step-by-step method to do this every single time without failing. Step 1, determine your level for problem complexity. Step 2, score the data. Step 3, score the risk. And step 4, just pick the middle or second highest level. So for example, if 2 of your elements score is high and 1 comes in low, your final code is high because you met that threshold for 2 out of the 3. Make sense?
Let's wrap up with section 5, common exam pitfalls and cheat sheet.
We are tackling the real boss battles of the CPC exam here by exposing the most common audit traps coders fall into. First up, scoring data the wrong way. Do not count a single lipid panel as multiple separate tests just because it checks for different things. No way. The right way? You count each unique test order once. You never ever double count individual components of a single unique test panel.
And here are 2 more massive exam traps. Seriously, these are such easy points to lose if you aren't paying close attention. Pitfall 1, misclassifying prescription drug management. Actually, scratch that.
Just don't forget it. Remember, prescription drug management is always moderate risk. Pitfall 2, failing to recognize social determinants of health, or SDOH. Listen, if a patient's diagnosis or treatment is significantly limited by their social situation, like housing insecurity, that legitimately drives their risk straight to moderate. Don't miss that on the exam.
Okay, take out your phones or hit print screen right now. This is your ultimate one-page visual summary cheat sheet. It summarizes all those problem data and risk thresholds right alongside the 2 out of 3 rule. Take a second to lock in this MDM knowledge for test day.
So we have officially conquered the MDM table. But what happens when a scenario gives you total provider time and suddenly you need to factor in time-based coding for office and outpatient services? Well, that is exactly what we are covering in Part 77. So keep that binge watch momentum going, and I'll see you in the next explainer.